We're going to move on to session number 5, moving from measurement to improvement. My name is Ted Skolarus. I'm a urologic oncologist, health services, and implementation researcher here at the University of Michigan and the VA Ann Arbor HSR&D Center for Clinical Management Research. Today we're going to hear from Drs. Justin Dimick and Dr. Skip Campbell about using the quality improvement tool of a surgery quality improvement collaborative to really improve two aspects of surgery: the technical delivery of surgery through video analysis and coaching. And then we're going to move on to Dr. Campbell's talk about improving perioperative process to decrease surgical site infections through a combination of audit and feedback and best practices implementation. So Dr. Dimick is the George Zeidema Professor of Surgery. He's Chief of Minimally Invasive Surgery here at the University of Michigan Department of Surgery. He's a Director of Center for Health Outcomes and Policy here at U of M, a group of over 100 faculty and staff looking at ways to improve the quality and efficiency of acute and specialty care. He's a national leader in health services and health policy. He's the chair of the NIH AHRQ study section. He has independent funding from NIH and AHRQ to look at process and policy evaluations in surgery. He's the PI of the T32 grant here at the University of Michigan to really train the next generation of surgeon scientists. He's been extensively published in broad readership and general surgery and surgical journals. He's been an advisor to many healthcare leading healthcare organizations here in the United States. He's also co-founder of Arbor, which is a software and analytics company that really helps institutions measure and improve their quality of care. The next speaker will be Dr. Campbell. He's a professor emeritus of surgery and the director of the Michigan Surgery Quality Collaborative. He's a leader in solid organ transplantation and surgical quality improvement. He is a former chief medical officer here at the University of Michigan Health System, where he was in charge of overall quality for the entire health system. He's won many awards, including the Eisenberg Award for Patient Safety and Quality from the NQF and the Joint Commission. He's currently the chair of the Technical Advisory Panel on Healthcare-Associated Infections for the NQF. He's extensively published, and we're glad to have both of them here to share their insights. So we'll move on to Justin's talk.
This has been a great conference, and I hope you enjoy the second day. I've been really enjoying what I've seen so far, so congratulations to the organizers. It's really been wonderful. Yesterday I was in the operating room, but I was following it on Twitter in between cases. So before I get started, let me just go through some disclosures here. So I do have grant funding, as you heard, from NIH and AHRQ. I'm a consultant for a lot of groups on quality measurement, and I'm co-founder of a startup company called Arbor. So normally when I give this talk, which is going to focus a lot on our own Blue Cross Blue Shield Collaborative, I start with this slide here to orient you to Michigan, and then I talk a little bit about how it's different, a lot because of the leadership from Dave Scher. But since you all heard about that yesterday, I'll just point out today that if Trump becomes elected, those of us in Michigan have a really short escape route to Canada. And as I said, you know a lot about these things, the collaboratives, and I know you heard about them yesterday. The one I'm going to speak about today specifically regarding our video-based coaching initiatives is the Bariatric Collaborative, which was founded and run for many years by John and Nancy Berkmeyer, and we have John come up as our keynote speaker. It's now run by Amir Ghaffari, who's in here somewhere. And I'm going to talk about a lot of the great work that built on the leadership of John and Nancy early on. I think one of the tenets of these programs is this idea that it's not just about measuring quality. And this little quote from Don Berwick was taken from an editorial he wrote after we wrote a paper in JAMA a few years ago that showed that simply enrolling in NSQIP doesn't improve your outcomes. Surgical outcomes are getting better pretty much for every procedure, slowly over time. There's a slow secular trend. But enrolling in NSQIP and signing up and just getting reports isn't enough. And Don Berwick wrote in his editorial on that just weighing a pig doesn't make it fatter, implying that you need to feed the pig if you want to make the pig fatter. Now, making the pig fatter in this context is quality improvement, is improving quality, and I think we take this very seriously in the state of Michigan in these collaboratives, and we work really hard at using our data to implement change, and I think you'll see that both in my talk and in Dr. Campbell's talk, who's coming up next. So just a little bit of the MBSC highlight reel on things that were done over time. You know, a lot of focus early on was in perioperative care, which I think you're going to hear a great talk from Skip Campbell on. We started with things like VTE prophylaxis. When we started doing this, it was very, you know, the surgeons all came in, they kind of had their arms crossed. There was a lot of, you know, not a ton of buy-in. I think starting somewhere safe, like let's all agree on how to give venous prophylaxis was a really important, starting something that we were psychologically safe. And so that's where we started. We were able to reduce venous thrombus embolism, and through that, reduce mortality. And I think I just told you a second ago that there's a secular trend towards improved mortality. But if you look at this slide here, published by actually Dr. Scher and Dr. Birkmeyer, you can see that bariatric surgery mortality was going down faster in the state of Michigan due to a lot of these efforts than it was everywhere else in the country. And at that time, bariatric surgery was the safest place in the country, or Michigan was the safest place in the country to have bariatric surgery. Now, we launched a lot of other quality improvement programs that I think contributed to that. But I think what you don't see in this graph, which ends in 2009, is that we actually hit a plateau. And the plateau, you know, we kind of were sitting around scratching our heads, and you know, I think it became apparent to us that we needed to focus less on perioperative care. We'd kind of squeeze the juice out of that and take this leap of figuring out what's going on in the operating room and figuring out if we can get into that black box of surgery. And this was, you know, once again, pioneered and led, and this was John leading this initiative around technique and technical skill. And I think this is really was a turning point for a lot of us in the way we thought about quality, because quality had been synonymous really in surgery with perioperative care improvement. And you need to do that, right? You need to focus on optimizing perioperative care and reducing complications. You need to focus on rescue, which is a really important way to reduce mortality. Those are really important things. But what are we going to do to focus to improve the quality of the operation itself? Now, we decided to use a video. We study laparoscopic bariatric surgery. Now, video has a lot of really useful attributes. First, you can just hit record and a laparoscopic camera, and it's there. But I think the other thing is that surveys and operative reports are almost useless. You can ask a surgeon what they did, but you're going to miss everything that they didn't know that they did or that they don't remember that they did. And that's a huge source of potential improvement information. Video has all of that. So these perception gaps, you know, the things that people are missing. And I love this study. This is a great study that I think is not a lot of people see. But they basically went for laparoscopic cholecystectomy, which I know you guys, a lot of you are urologists, so don't do. But the key step in that procedure is called a critical view of safety, where you clearly visualize the anatomy going in and out of the gallbladder before you clip it. And what they did was they looked at operative notes, and 100% of surgeons say they achieved a critical view of safety. And then they looked at the videos, and only about 43% of the surgeons actually achieved a critical view of safety. So this highlights that perception gap, right, between what the surgeon thinks they did, and I don't think they're lying. I think they thought they achieved a critical view of safety, and to their standard, they achieved it, but to somebody else's standard, they didn't achieve it. So once again, I think this was an incredibly valuable source of quality improvement information. So that brings us to our pilot data here, and this was John's really last health services research paper. He didn't get here earlier enough today to, before he went into health systems leadership, when he left a primary research role, he just went like this. But I was trying to get a picture of John dropping a mic, because this is really John went on to a health system leadership role. This is his last paper. He first author paper he published before he left, and he's kind of like, I'm just going to leave this here for you all to think about. And I think it got a lot of attention. But in this paper on surgical skill was really the pilot data for the rest of the work I'm going to talk about here. And what we did was we had surgeons submit a typical videotape of a laparoscopic gastric bypass procedure. Now, what do you think when you ask surgeons to send a typical videotape? What do you think they send? Like the best one they ever did, right? That's the typical one. And so you watch these videos, no one ever makes a mistake in these. These aren't people who had complications, especially intraoperatively. And the patient's BMIs, by the way, this is bariatric surgery, their BMIs were 34.9. There wasn't an ounce of fat in these videos. Clearly, they were optimized. But what does that do? That biases us towards the null hypothesis, right? If you have everyone's best tape, and you don't find a signal, then you're going to say, well, maybe if we got different cases, we'd find that. But you'll see what we found. We essentially had 10 surgeons from around the state in our collaborative review each other's videos and get a score. And we used something called the OSAT score, which is a objective structured assessment of technical skills. We often use it to grade residents. For this, we modified it in a very sophisticated way. We just changed the anchors from junior resident to senior resident to the bottom anchor of chief resident and the top anchor to master bariatric surgeon. Apologies to any chief residents in the room. But we basically changed the anchors, and we had surgeons rate each other's videos, and this is what we saw. We saw, not surprisingly, a fairly wide variation in peer-rated video assessment across surgeons. And there was no one that was a 1, but there were a lot of people that were in the 2s, and then it varied all the way up to one video that was a 5, and everyone kind of agreed it was 5. You can tell by the confidence band around that. So then what we did, which I think is why this got into the New England Journal and why this was fairly unique, was we divided the surgeons into 3 groups and then looked at their outcomes. Because remember, not their outcomes with this patient that this video was taken on, but with their last 200 cases. So think about this as the video is a proxy for their skill, and we're going to see how that proxy correlates with their last several hundred cases using risk-adjusted outcomes because we have a detailed clinical registry. Before I do that, I'll let you look at a few videos to get an idea. And these are videos that are poached from the New England Journal paper as well as reproduced in the New York Times on an article that covered it. And you'll notice here the top surgeon is Dr. Birkmeyer and the bottom surgeon is me. Just kidding. I can't tell you who they are. No disclosure. Actually, I'll tell you neither of these videos is either of us. But what we'll do is we look at these for a second, and then I'll have you tell me, if you needed bariatric surgery, which surgeon you would want. And the domains we look at on the OSATs include dexterity, efficiency, tissue handling, those types of things. There's so many ways I can answer that. I'll just say because they don't need to. All right, so who wants surgeon A? Who wants surgeon B? Right, so think about the power of that, right? You just watched a 1-minute clip of these surgeons operate, and with 100% reliability, you pick the higher surgeon. If I show this to high school students, they also nail this with 100% reliability. Now, I'll tell you that these are extremes. These are one of the top and one of the bottom rated videos, so that makes it easier to discriminate. In the middle, it gets harder, and if you saw, remember the curve that Andy showed of risk-related outcome, there was some noise in there, especially in the middle. But as I said, the key take-home point was this. When we looked at those surgeon ratings and looked at their impact on outcomes, you can see a very linear relationship between how surgeons view your skill and outcomes. It was stronger than the volume relationship. It was not totally correlated with OR time. It wasn't totally correlated with volume. There were some highly rated medium volume surgeons. I don't believe there were any highly rated low volume surgeons, but the volume was a less perfect proxy than skill, in other words. Now the problem is, this was our preliminary data, and the question is, we're not a quality assessment collaborative, we're a quality improvement collaborative, so what do you do with that data? So we went out and thought about this, and thinking about ways we have in our organized professions to improve the skill of practicing surgeons. And there's not a lot out there. Think about how surgeons normally learn a new skill or technique. They take a weekend course, they do a cadaver, they watch some videos, they may, in robotic surgery we talked about before, you may have to be proctored in 2 cases, I think is the standard in a lot of places. One time I was giving this talk in Australia and somebody said, it's totally different here, it's 1 case. And so I think there's a lot of room to be improved in how we learn new things. And I think this research informs that, but the current standards aren't that great. Simulation, there just aren't any high-fidelity simulators for bariatric surgery that I know of. They're really for manual dexterity improvement among novices. So we went to the New Yorker for a research idea, and we went back to this great piece by Atul Gawande, who wrote this wonderful essay, and he asked the very simple question of why is it that surgeons who rely on peak physical performance to provide a good outcome don't have coaches, whereas other professions where they rely on a peak physical performance do. Whoever wins Wimbledon every year has a coach. Right? They're pretty darn good, but they still are learning. And some of the quotes I pulled directly from Atul's article here is that traditional learning paradigm, which is how we learn in surgery, is there's a presumption that at some point you're done. You're done with your training, you're done with your fellowship, you go on, you're on your own. Whereas a coaching paradigm considers that model naive if we all want to achieve our best performance. And a coaching model moves beyond that to create structured ways in which you continue to get feedback and advice for improvement. Now, there's no doubt those who become master surgeons are always looking for this advice, but there's just no structured way that it moves forward. There's not a lot of data in surgical coaching, but there is from a lot of other fields, like teaching teachers new skills. There's really great randomized trial data. And as you can see, lectures work okay, feedback's okay, but coaching really helps people implement new skills. And why is that? The theory here is that when you're implementing something in practice, there's 1,000 different ways it can go wrong. If someone gives you a lecture or gives you feedback, you don't have the 1,000 solutions to those 1,000 problems. If you have a coach with you, they can pull out the 2 or 3 things you need out of those 1,000 problems because they over their cumulative experience, know how to solve those problems. So that's sort of the theory behind why coaching works. Caprice Greenberg was the person who did all that work that Artul wrote about in the New Yorker, and she subsequently moved on to the University of Wisconsin and has developed a coaching model that she's learned by doing qualitative work with coaches in other fields and then translated it into surgery. So we had this preliminary data from John's mic dropping paper there and Caprice's conceptual model. So we wrote a very big R1 grant that we sent to the NIDDK to develop a coaching intervention for the state of Michigan, which they funded. And so we are now about a year and a half into this process, and our coach training, everyone felt very strongly that they wanted surgeons who were highly rated to be their coaches. It's true in athletics that the best coaches aren't the best players. Some of them were, some of them weren't. But our surgeons felt very strongly they wanted top-notch surgeons to rate them. So we've been training them, we trained them in the training program in feedback and how to give good feedback as a coach and how to hold and engage a coaching conversation. And we enlisted 15 coaches. We made sure we had the highest rated people among each technique so we could match people based on how they did the operation because there were likely to be some aspects of coaching that are technique dependent. And we employed an executive coach, a friend of mine, Janet Dombrowski, to help us with the coach training process, as well as Caprice's team came down. And we trained our coaches over a course of 6 months. We needed 12 to meet our criteria of enrollment. We asked 15, all 15 signed up, and all 15 showed up for the training, which I thought was great. And we did our first video-based coaching session a year ago in October. In the terms of the training, we came up with a great resource manual that was kind of co-branded with MBSC and the Wisconsin Surgical Coaching Program. One of the most useful things we did was role-play coaching. We essentially had, these are 2 coaches here, going over their video in public in a group, and we had our executive coach kind of giving them feedback on how they were engaging the other surgeon in coaching. And this was tremendously helpful, both for the people that participated, but also for the whole room. And then we went on to implement our coaching program, and this is basically what it looks like. You see coaches and coachees sitting around a laptop watching their video and getting instruction. Little cafe tables. We had about, I think, 12 tables at this particular coaching event. And just a few more pictures of what it looks like. You can see how engaged people are in this. And I'll tell you right now, these are not posed pictures. We didn't go around and say, okay, look engaged, we're going to take a picture right now. You know, people just find this highly engaging. And beyond the coaching, and I don't have any results for you yet because the study's still ongoing, we're doing both qualitative and quantitative assessment. We record all the coaching conversations. We have a little recorder set up with everyone, and we're in the process of looking at that data, and we're giving feedback to our coaches in an ongoing process in their coaching style to make them better coaches. But another useful thing about this is we have all these videos now. So we're collecting videos, and sleeve gastrectomy is a bariatric procedure that just kind of took off in terms of the proportion of bariatric procedures. So we thought we had all these videos, let's use these as well. And there's a lot of variability in outcomes for sleeve. It's probably not related to volume. So we wrote another grant to use those videos to do some understanding best practices and implementing them. And to do this, it's a little different than coaching because we wanted to understand those kind of micro details of care and how they relate to outcomes, right? Everyone argues you should do it this way, you should do it that way. But we figured we could come up with some good epidemiologic data about which best practices lead to the best outcomes. So we have a video assessment, and just to show you some of the kind of standardized views we look at, we want to know, do they evaluate well enough for a hiatal hernia? Because people think if you miss a hiatal hernia, that gives you bad reflux. We're looking at mobilization of the fundus. Was it completely mobilized? Some people think if you don't mobilize it all the way, you end up with it pooling there and reflux or poor weight loss. Distance from the incisura is another step we're studying. The incisura is that little angulation in the stomach. And people think if you get too close, the stomach gets kinked, and then they get reflux or stricture. People think if you take out too much of the antrum, the stomach doesn't empty well, which leads to reflux, etc. So there's a lot, as I said, a lot of people arguing about this operation. This is my favorite because this is the GE junction staple fire. Whenever I show this to bariatric surgeons, half of them are like, oh, that's way too close. The other half are like, yeah, that's exactly how I do it, which goes to show you the variability in technique and how it's done. And then we have a leak test as well. So I think in general, both these projects are aiming to introduce innovation to the learning curve, right? We call this a learning curve. That's really a euphemism. Really, this is the unnecessary patient harm curve. And it's behooving us to shift that up, right? Minimize that patient harm. I think in surgery, we're good at innovation, but we're not particularly good at innovating the learning curve to make it sharper or shorter. So I think my closing thought here that I'll leave you with is that these video assessments and coaching, I think, are a great way to put surgery back into surgical quality improvement. As I said before, perioperative care optimization is important, rescue is important, but also improving the quality of the operation that we perform is increasingly important. I think going to be easier with all the digital media that we have available to us now, especially in robotics, with laparoscopy taking off as well. And some people are toying around with using video to assess open operations like trauma laparotomies, et cetera, and even capturing the whole team. So I think all of these things are great opportunities for us to dramatically improve our approach to surgical quality improvement. Thank you.
Thank you, Justin. That was a very inspiring and motivating talk about some innovative ways to improve the technical aspects of surgery. Now we'll have Dr. Campbell talk to us about his Surgical Improvement Collaborative and their efforts to reduce surgical site infections.
Thanks, Ted. Thanks for inviting me to this great conference. I really enjoyed it in its entirety. I want to talk a little bit now and switch gears to this idea of perioperative processes and how can we take big data, and we've got a lot of big data that we think is relatively good, but how can we use it to inform a quality improvement strategy that is, for lack of a better word, implementable across 73 different hospitals and then can be transformed into a tangible benefit for our patients, which is the thing that we want to do. So I've entitled this Big Data to the Bedside. I have to talk a little bit about MSQC and what it actually is, and by way of disclosure, Blue Cross Blue Shield, which supports this whole endeavor, also supports part of my salary. We've been in existence for about 10 years. There are 73 hospitals that participate in MSQC. We have plans for another 20, which will essentially be all the large hospitals that participate in big surgery throughout the state. Every one of these centers has a surgical nurse data collector who collects data from the electronic medical record. This is not administrative data in any way. And then there's a surgical champion at each hospital also who helps implement some of our strategies. That information comes back to a server at Arbor Metrics, and Arbor Metrics processes the data and then feeds it back to the individual hospitals and surgeons in essentially a real-time basis. And while there are 73 surgeon champions, there are approximately, well over 2,000 surgeons and gynecological surgeons who are at least have a dotted line relationship to MSQC. So there's a really large cadre of surgeons here. So just some interesting facts, I think, about MSQC. In the 10 years or so that we've been working, no hospital has dropped out. It's kind of remarkable when you think about 73 different hospitals. They've all stuck with it. There's general surgery, vascular surgery, and gynecology more recently has been added to what we study, 137 variables per case. Over 50,000 cases of this clinical data comes into our database every year. We're a certified patient safety organization, which I won't have time to go into, but we think it's very helpful. And this is supported entirely by Blue Cross Blue Shield, and many thanks to David Scher and Tom Simmer and many others who I think have really been visionary in terms of this idea. So this is basically something I think you probably already know, but this is the backbone of what we do. We develop a surgical registry. We use the registry to examine variation in quality. We identify best performing hospitals. We identify the best practices in the best performing hospitals, usually by a combination of methods, but including site visits to those hospitals. And then we try to distribute and disseminate that information in a variety of ways that we do that. Also, quarterly meetings, annual meetings, regular surgeon champion conference calls with essentially 70 surgeons on the phone at 6:30 in the morning once a month, as well as regular nurse reviewer conference calls, a newsletter, workshops, tools on the website, a variety of different strategies we have to get out information, which I think is a lot different than the usual surgical meeting where somebody stands up and presents some data, and then it takes a year for it to appear in print, and what happens to it then. So Ted asked me to summarize in a way what I think has been the important features of MSQC that has resulted in this 10-year sort of course. And I think we have to start with the culture, the idea that you don't get anywhere in a collegial and collaborative kind of relationship if people don't like each other and they're competitive with each other. And so the culture really is a very important factor of this. With high standards, and we get non-threatening kinds of conversations within our meetings. It's non-competitive, lots of engagement from the surgeons and the nurses. And one thing that really turned out to be very important is this customer service idea, because the nurses who are not necessarily IT savvy when we hire them, or statistically knowledgeable either, have a lot of questions. And if their phone calls don't get answered in a very timely manner, they get demoralized, basically, and the whole thing starts to fall apart. So we realized early on we had to have patients or the nurses' phone calls answered within about a 24-hour period of time. Otherwise, it didn't work. And then the final thing I think is the most important part of MSQC, and the most fun part for me, this idea that there's a platform for discovery and innovation. And I think that benefits not only the patients, but also Blue Cross Blue Shield, which doesn't have another good way to get into these different new areas. But none of that culture would happen unless you had some structure, obviously, and I tried to list here what some of the structural features were. Certainly the financial support is the most important, probably, but we have to have reliable data that the doctors believe in, so the surgeons in our group help to develop all our metrics and define what they were. The regional rather than national sort of organization, I think, is very important, right? We tried on the national level for several years with NSQIP, and it didn't really work for us very well. We couldn't get close enough to the players, and we didn't know each other, and it just works better when we have this autonomy, and David mentioned this, that's a big thing for surgeons to have autonomy and mastery, and the sense of purpose, which I think is easier to generate on a regional basis. And it's multidisciplinary. We involve our nurses very heavily in what we do, and that's, I think, a little unique too. In surgery, we don't usually invite the nurses to our surgical meetings, but in this particular case, they're sitting right next to the surgeon champions in the meetings that we have, which I think is very important. And I won't have time to go into this either, but one of my favorite things is the site visit, getting into those hospitals. And of course, if you don't have the right culture, they don't let you into their hospital. They don't want to give up their secret sauce, as it were. And I think that's tremendously important. So Chuck Record, this is a picture of one of my favorite people. Unfortunately, he died a few years ago of a brain tumor, but he was a professor of surgery at Harvard, and he basically started what is now the NSQIP. But his advice to me always was a friendly relationship with your colleagues so that they will trust you and work with you to try to do what you want to do. So now I'm going to get to this part about the big data to the bedside. Our idea was to try to reduce the incidence of SSI in colectomy patients, and we focused on colectomy. It's sort of like how the STS focuses on CABG, but this is our case. We're mostly general surgeons. It's a commonly performed procedure, high incidence of infection. In this particular group of studies I'm going to talk about, there's around 6,000 patients in 73 hospitals that involved 22 separate CPT codes. There was these 137 data elements per case. And the question is, what did that tell us, getting all that data together? So this is the first time we put all of our information into a logistic regression analysis to try to find out which factors were associated independently with a lower SSI rate. And this is what came out of it. the normothermia, the idea that you maintain body temperature, a bowel prep with oral antibiotics, and I'm going to be talking about that in more detail, so I'll tell you exactly what that means. That means that if you must flush the bowel out, get the stool out of it, and then follow it with an oral non-absorbable antibiotic to increase the antibiotic concentration in the mucosal cells of the colon. And that is something we feel is very important, and I'll discuss that later. A laparoscopic approach was important, a short duration of surgery important, post-op day 1 glucose less than 140, that is to say normal glycemia throughout the perioperative period, and skip to compliance. SKIP meaning the Surgical Care Improvement Project. There are a list of 7 or 8 antibiotics that are thought to have the appropriate spectrum to cover colon surgery, and SKIP 2 compliance turned out to be statistically important there. Whereas SKIP 1, the idea that timing of antibiotics in the 60 minutes prior to surgery was important, that really didn't fall out in our analysis. So in any event, of all the many, many different variables we put into this analysis, these 6 came out as independently associated with a lower SSI rate, and we started to call this our bundle. And now I'm going to digress just for 1 second and tell you about these interesting people, Emil Freireich and Emil Frey. And I was reminded about this story last week when my wife and I went to hear Malcolm Gladwell at Hill Auditorium. And the story there that he told about these 2 real paragons of oncology was that what they found themselves in a leukemia ward of children at the NCI in the early 60s, and the leukemia at that point was uniformly fatal for these children, and the typical treatment was to treat them with an antimetabolite of some kind, 6-mercaptopurine, for example. But singly, they just used 1 drug, but their insight was to use combination chemotherapy, thinking that they could lower the dose a little bit, but add 4 or 5 drugs at one time, and it might be more successful. And indeed it was, and the success rate now for treating childhood leukemia is well over 90%, basically because of this idea. And it occurred to me as I was listening to this that there are other parallels in medicine, many other parallels, where this kind of phenomenon is important. And then this gets back to this idea of our bundle and our 6 factors. If any one of these are used individually, typically, there's not that much of an effect. It may be statistically apparent, but not clinically apparent. But what would happen if you were to use all these 6 bundle elements in a given individual? And so we looked at that. And we went back to our data and looked at each individual 6 of the 6,000 colectomy patients that had this information, and what would happen if you only had 1 of these variables, 2, 3, 4, 5, and 6 of these variables. And the slide that I'm going to show you now is one of the most remarkable slides I've ever seen, and I couldn't have drawn it better to illustrate this point. But this is what it looked like, where the SSI rate by bundle score looked like this. So if you had only 1 of these bundle elements per case, the infection rate was almost 20%, which is typical for colon surgery. But progressively, as you added more of these factors, well, I shouldn't put it that way. So the more of these factors that were evident in each individual case, the less the infection rate was. And when the 105 patients that had all 6 factors, there were 0 infections. There weren't any. And that's unheard of in colon surgery. So it was really a remarkable finding, I think. And then we went back to all our hospitals to see how prevalent was this practice of putting all these things together. And you can see on the x-axis here the different hospitals in MSQC, and on the y-axis the average score of these bundle elements, and the averaged around 3.5 or something like that. But there were some of the hospitals had really gotten the message and were pretty good at this, and then other hospitals weren't so good at it. And the question then becomes, what do you do with those hospitals that are not so good? These hospitals down at this particular interval, they just don't seem to be participating in this. So we had a broad spectrum approach to this, and I highlighted in red here our bundle elements, where we had external speakers come in, and we had panels, and we sent out newsletters, and we did all sorts of different things. And there were other strategies that we used as well that I put on there, for instance, an emphasis on weight-based dosing, and another one is on redosing and surgery that lasts for more than 3 hours, and so forth and so on. But the main factors were our bundle elements that we tried to look at. But we here needed some focus because you can't just do everything at once. You have to sort of decide what is the most important factors here. And so we looked at this slide here, which shows you the variation by bundle elements in our series. And what you see here is that at the bottom of the screen, for instance, normothermia, there's not much variation. The hospitals seem to be able to do that fairly well. They all do fairly well. On the other hand, if you look up at the oral antibiotics with bowel prep factor, there's a lot of variation. Some of the hospitals didn't do it at all. Others did it quite frequently. So that looked to us like something we could modify fairly quickly as opposed to something like minimally invasive surgery. You know, that's going to take a long time to convince people that they need to learn how to do laparoscopic surgery if they didn't already know how to do it. And likewise, the short duration of surgery. Other than what Justin was just talking about, the idea that you can improve somebody's duration of surgery, which turned out to be important in this analysis, that's kind of hard to do. That's going to take a long time before you're able to do that. But the modifiable factors is the oral antibiotics part of it, as well as the normal glycemic part of it. We could do that fairly well. The second thing we looked at is trying to understand what the importance of these factors were in what we were seeing here. And what we saw was probably the most important factor in terms of explaining the variation was minimally invasive surgery. But the second one was oral antibiotics and mechanical bowel prep, and then post-op normothermia was down at the bottom. So it made sense, since there was a lot of variation in the performance of the oral antibiotics part, it was modifiable, and it seemed to have a pretty good weight in this system, then why won't we focus on getting doctors to prescribe oral antibiotics as part of their bowel prep? So we published a paper about our experience, and it was kind of a natural experiment because many of the surgeons didn't use oral antibiotics. They just used a mechanical prep only, and the other half of them used oral antibiotics with the mechanical prep. So we did a propensity match kind of analysis and presented this at the American Surgical Association. And this is what the data showed, which was that the black bars were those cases, the infection rate in those cases that did not receive oral non-absorbable antibiotics, and the gray bars were those that did, and it was a very significant finding. But then there's something that, there were despite this data, there was quite a few surgeons in our group who weren't buying it, basically. They're not going to change what they used to do 20 years ago in their residency for anything. So we had to sit around and use sort of informal communication mechanisms to talk about why they didn't want to use oral non-absorbable antibiotics. And you cannot get this kind of information out of a database. Computer's not going to tell you this. You have to stand around the water cooler and have panels and interact with people to understand why they don't want to do this. And so the three themes that came out of this was that some of the surgeons were concerned that it might increase the incidence of Clostridium difficile after surgery. Some of them thought it was not necessary for a right colectomy. So a right colectomy, they say, well, it's kind of like doing a small bowel resection. We don't use oral antibiotics for small bowel resections. Why would you have to do it for a right colectomy? And then some of the surgeons were looking at the European data, which seemed to suggest that you didn't need a bowel prep at all. You could just operate on somebody's colon full of stool and it wouldn't make any difference. That information, however, I think was very flawed information because the Europeans typically didn't use oral non-absorbable antibiotics anyway. So when they did their randomized prospective trials, they were really looking only at mechanical prep versus nothing, and they didn't see any difference. So that information sort of got misinterpreted in my idea. But we decided, well, let's go back to this big data and see if we can answer some of these questions that the surgeons had. And the first time we did this was the C. diff question. We looked at that, and we saw that the oral antibiotics and no oral antibiotics, the C. diff colitis following surgery was basically the same. So we put that thing to rest. Second one was the site of resection. So we said, well, we can divide this up into right colectomies and left colectomies and look to see if there's any difference there. And in fact, we saw no difference at all. It was equally efficacious if a right colectomy was done as a left colectomy. And I subsequently found out from my friend Don Fry that the bacterial content in the right colon was even higher typically than it is in the left colon. So this made some sense in that way. And then the third thing was, what about maybe we don't need to have a bowel prep at all. So again, we had some surgeons in Michigan who had adhered to that kind of philosophy, and they weren't using anything. And then we did this propensity kind of matching approach again and found that Well, no, the oral antibiotics, and we typically called that the condom prep, with the mechanical prep, there was far fewer infections than if you didn't use anything at all. So those three arguments were then put to rest by using our data. So now, none of this would make any difference if this slide that I'm showing you right here, which is the percentage of cases that were done with oral non-absorbable antibiotics, if that was a flat line, or worse yet, going down, I would not be up here. I wouldn't know what to say. We really worked hard on this particular aspect of things, but yet it has gone up. It's gone up pretty dramatically. In fact, when we first started, it's not on this graph, but when we first started, it was 35% of surgeons, 39% were using oral antibiotics. In Michigan, now it's up over 70%. So something we did is causing them to increase the incidence of what we think is a very powerful part of our bundle. And then if you look at the bundle score itself, that does seem to be going up, and it's not going up as much as I had hoped, but I think part of that is explained in this slide, where you see that the operative duration actually didn't change very much. And in fact, the percentage of cases that were done in a short period of time went down, maybe because they're learning how to do laparoscopic surgery, I'm not sure. But we made the most progress with the oral antibiotics, but second most progress was with the post-op day one glucose, which it also worked on. And then in any event, most of them went up, and overall, it went up around 8%. I don't know if that's good, if that's bad, at least it's going in the right direction. So I need to show you the results, and this is what the SSI rate looks like in colectomy over this period of time, a pretty nice drop. And I've worked with Justin for many, many years, and so I know how his brain thinks, and I know he's thinking to himself, well, there's these secular trends. How do you know that what you think you've been doing had anything to do with the results that you're showing? And so I just pulled out some data from the PUF file from NISQIP that was matched by date and CPT code to show him this. And the red line is the NSQIP outside the state of Michigan, and the blue line is MSQC, and those two slopes are different statistically. So that's, Justin, that one's for you. So then this is an important slide, I think, that I like to show this to David. I think I've showed it to him many times, but this requires a little bit of explaining. The composite score on the x-axis here is a composite that we made for colectomy quality. It's not just SSI rate or mortality or something. It's 5 different domains: mortality, morbidity, process measure compliance, resource utilization, and anastomotic leak, all kind of glumped into one composite measure. And then on the y-axis is our 90-day episode cost that we get from MVC, the Michigan Value Collaborative. And you see that slope, the better quality that you have, the less Blue Cross Blue Shield had to pay us. So this essentially is a justification for these quality improvement activities that we do. If it was going the opposite direction, we'd have a lot of explaining to do, but it's not. It's going in this direction. So I think that's an important observation. So just to finish up here, we also look now at skip 2, the 7 or 8 antibiotics that I talked to you about being, my friend Patch Dellinger frequently calls it eminence-based data rather than evidence-based data, but these antibiotics got on this approved list, and we wanted to look to see if all 8 of them were equally efficacious. Now I'm talking about parenteral antibiotics here, not oral antibiotics. And what we saw was this, that there were like 240 different permutations of antibiotics used for colectomy surgery in Michigan, not good. And these were the sort of the order of use that they were in here. And then when we did the same sort of logistic regression, we found that there was only 3 of them were statistically important in terms of also adding on to the other factors that we had seen. So we've had this strategy to also refine the parenteral antibiotic use in Michigan, and I haven't really analyzed that just yet. So I'm going to finish up by just telling you this. I've tried to emphasize this idea that a multiple factor approach to a problem like SSI is important, and my colleague Dan Morgan, a gynecologic surgeon at the University of Michigan, has done a great job in leading our effort to analyze our hysterectomy database, which now I think has over 25,000 cases in it. And they put together a bundle which looks like this with 4 factors: appropriate antibiotics, minimally invasive approach, operative time less than 2 hours, and no hemostatic agents, which in another paper turned out to be an important factor for reasons which I'm still not entirely sure. But in any event, that's the bundle that they've used, and when they've looked at that bundle in an outcome that looks at all morbidity, not just SSI, you see the same kind of relationship that the results improve dramatically. So I think the bundled approach is something that we probably can apply to many, many different areas in surgery. So now I'm 1 minute over, so I just want to end up by having a bigger picture kind of comment here. David and his colleagues have supported these CQIs, but also the physician group incentive program, which was more primary care and internal medicine oriented on the left side. And there are these 45 physicians organizations in Michigan and the 22 hospital-based specialty CQIs. And I think what we need to do in the future in order to get us to a different quantum level of improvement is to join these in a way that we haven't done before. And we've tried to do that with our rehabilitation program, where we work with primary care to improve the condition of patients in the 30 days prior to surgery with the hopes that their results will ultimately be better. Mike Anglesby, my colleague, got a big grant from the Innovation Center to put that program in place in 40 of our MSQC hospitals. So I'll stop on that note. Thank you again for inviting me to present at this wonderful conference, and I'd be happy to answer questions.
Yep, Justin, come on up. So we have a few minutes for questions. I think that is a tremendous display of the opportunities that Surgery Quality Improvement Collaboratives has as a tool to improve quality. I think just put a plug in for implementation research and opportunities that are present to understand the best ways to implement these evidence and expert-based opinions and practices into the clinical practices and understand how context matters for success. Seth has a question.
Seth Strope, Washington University. I was curious about the use of the surgery operating time in the assessments that you were showing, because is that really a marker of the difficulty of the individual case or the quality of the surgery being performed?
Yeah, I have no idea. I mean, there could be either one. That's just a factor that we can measure, and that we put that factor into our analysis, and that's what comes out. But I would leave it to Justin to help us understand that part.
It's both, right? We know it's both. Right? It's both. There are faster surgeons and slower surgeons, but from the improvement perspective, and this is, I'll quote John Berkmeyer, who always says, hurry up is not a good quality improvement strategy, right? So you have to understand the root factors of what it is, and if it's differences in skill.
Okay.
Hi, I'm Michael Chair from Wayne State University. Dr. Campbell, you said that some of the data put some of the arguments to rest, and you still had surgeons that were not complying with the bundle, and then you mentioned conversations around the water cooler. So I'm just curious if you could expand on how you get the recalcitrant surgeons to change their practices.
Well, you probably can't get every surgeon to change their practice. We surgeons are stubborn people, and I actually haven't. You have to take into account two things. One, whether they're adhering to that process-based measure or not, and also what the results are, because these are, I showed you that straight line relationship, but there's a lot of other factors that we don't understand very well. So if somebody doesn't use oral non-absorbable antibiotics, but their infection rate isn't too bad, then I'm not going to argue with that. They may be doing something else that I don't know or I don't understand very well, but as long as their results are good, then I'm going to leave them alone. I think that it's when your results are bad, and we've already outlined a pathway to get better results, and you don't do it, that's when I pay attention.
Hi, Mia Woodward from University of Michigan. So in ophthalmology, we've been using surgical videos for a very long time because it's so easy with our operating microscope to do so. But recently, we've had a lot of issues, especially at the VA, for patient safety and patient privacy, because these are often done on USB drives. And I wonder if, from the administrators, have you had those conversations about alleviating those concerns or addressing those concerns?
So you're talking about protecting patient privacy with videos. So yeah, we have 2 funded NIH grants in this. So you can imagine I spent 6 months working with Health and Human Services to get a data management and safety plan together that suited everybody's, our IRBs, Health and Human Services, AHRQ, and the NIH. So I have a several-page document I can share with you. But the bottom line is we don't collect patient identifiers. People worry a lot about discoverability. We're talking about intra-abdominal, abdominal videos. You can't tell gender or race by looking at somebody's bowels. So it's pretty, there's not a lot of patient identifiers in there. There's nothing except the intraoperative, intra-abdominal part of the video collected. And then we immediately disconnect it from any patient identifier. So the surgeons are identifiable. We know which surgeon had which video, but there's no connection at the patient level, which allows us to, it can't be discoverable if you can't connect it to a patient identifier, basically. So it's not discoverable. There are a lot of other protections against that, against discoverability, but that just makes it impossible. So in terms of the research, in terms of the permissions, we basically get patient permission to use the video as, to be compliant with JCO mandates that you get patient permission. So there's a permission slip on their chart for use of the video for quality or education, et cetera, whatever. But then we have surgeon consent, because the surgeon is the one that has more than minimal risk, and we track and keep their consents and protect their identity as part of our study.
Justin, I have a question for you. When I was the chief medical officer, I tried to implement a video analysis of the operating room team dynamics, anesthesia, nursing, and surgery, and I basically got my head handed to me by all my surgical colleagues. Do you see that that's going to happen in the future? It just seems to me that it might be equally as important as operative technique.
Yeah, it's harder though, right? And I think because people are easily identifiable, and you can see them in real time. So I think it's quite different when you're actually capturing people's faces and the patient's face and body. So the medical legal implications are a lot different. Same with real-time coaching. People say, why don't you do real-time coaching? Well, if you do real-time coaching, all of a sudden you're changing the operation, which means you have to be consented as one of the physicians engaging in that operation, which totally changes medical legal things. So, obviously this is a really high-intensity quality improvement intervention, and we started where it was easy. Post-hoc video review of just intra-abdominal videos.
I think that's a nice segue into this question from Angie Smith. What are your thoughts on using a lay crowdsourcing as a cost-effective way to quickly identify poor performers from short video clips? So you alluded to that to some degree as we watched the...
Yeah, and I think it probably works okay to discriminate the really best and the really worst. But I think as you get into more intermediate levels of performance, it's harder to discriminate with lay people. And I think that a lot of the value in these videos assessments are going to be in giving people feedback on what they can do better. So I think, with our sleeve video project, I didn't have a lot of time to go into detail with that, but we're basically categorizing the technique. Did they do this step? Was this too close to the GA junction? How far were they quantitatively? Qualitatively, was this too close or too far? Which will help us understand how expert surgeons are viewing, or not expert surgeons, peer surgeons are viewing that step, to understand if peer surgeons' ratings can adequately capture differences in technique and things like that. And to me, that's where a lot of the interesting stuff is. Just are they good or not? Yeah, you could probably use crowdsourcing at the extremes, but not super helpful for a lot of the most interesting work to be done here.
Okay.
Hi, Zach Warden, Indiana University. I had a question about the antibiotic use and the surgical site infections. Did you, how did you account for any interaction or confounding between the choice of IV antibiotics and the use or lack of use of the oral antibiotics? Because as you alluded to on that slide, there were a good number, it looked like over half of those antibiotics that were inappropriate in terms of not covering the appropriate anaerobe.
It's a good question. Actually, I'll tell you a story about that. When we first presented our paper at the American Surgical about oral antibiotics, Hiram Polk, who is a sort of a paragon of general surgery, got up to the microphone and said, well, okay, so I understand that, but what about the parenteral antibiotics? Maybe some of the folks that had been using oral non-absorbable antibiotics also had a predisposition to use a different kind of parenteral antibiotic, and that was really what was the important factor, and you hadn't measured that. And we hadn't. So we went back, and that's when this bundle business came out, and what that is showing you, at least in the SCIP2 eminence-based category, is independently associated with lower SSI rates when the oral antibiotics are factored in there. It's also important. That's what that's telling you. So now, would it be even more obvious if you took only the antibiotics that we think work? Probably. We haven't done that yet, but it probably would be. But now we've taken this, you know, again, we're talking about getting data to the bedside. So we made a recommendation based on that, those 3 antibiotics. One was kefzolmetronidazole, and that seemed to be a pretty good combination because there's not a lot of resistance to it, there's not a lot of side effects to it. And so we didn't want to argue for ertapenem because of carbapenem resistance problems that we don't want to contribute to. So we basically sent out plastic laminated sheets to every hospital that this is what we think you should use. Now, we can't force you to do it. This is just information that from your collaborative that we're giving you, and we hope you'll find it helpful. So that's what we did.
Great.
Just, one other, like, just a quick follow-up on,
Sure.
did you account for the redosing intraoperatively?
Well, now that's a good one. I don't think I mentioned it on there. We started off with weight-based dosing, added that to our bundle, because a lot of the hospitals, in fact, most of them, were not doubling the dose of cefazolin with higher BMI patients, according to what the recommendations were. So that's been a subsequent effort, and we're getting pretty good on that one now. But the redosing, the antibiotics have different sort of suggestions for redosing. We just took 3 hours. If the case is going to go more than 3 hours, did you redose or not? And we're pitiful in that. The whole state is pitiful in that. It's like 10% of cases actually have redosing, but there's good evidence out there that that's important. So that's our next phase, basically, to work on the redosing.
All right, well, thank you for your questions. We're going to move on to our keynote address for this morning.